Hi, I'm Jack Cush. I'm here in the Room Now booth at ACR 2019 in Atlanta. We've convened a panel of experts on gout. I'd like them to introduce themselves.
I'm Nicola Delbeth from Auckland, New Zealand.
Hi, Jack Ken Sag, University of Alabama at Birmingham.
And Rob Keenan at Duke University.
All right, so there's been a lot of presentations here. Why don't we hear from each of you what you think was a highlight presentation that either struck you or that you were involved with?
Yeah. So, well, I think for me, the clinical trial that has been really interesting is Lisa Stamp's trial about tart cherries. So we know that patients often take different dietary factors or, different supplements, and there's been a lot of interest in tart cherry. It may well reduce flares, but we really haven't understood why. And Lisa's study has shown in patients with gout, tart cherry does not change serum urate levels. So if it works, it's going to work through a different mechanism, maybe through reducing flares, and I think that's really the next step. But really interesting to see some RCT data of these specific dietary factors.
It's been anecdotalism up to now.
Yeah.
That's true.
It's about time.
Yeah,
we need
absolutely.
a study.
We really do.
We need some data.
Yeah.
Patients like the idea, and they'll buy the juice and the extract and all that kind of stuff. But
What is it, though? Is it vitamin C or is
I don't think it's
is
vitamin C.
well, it's the mechanism would be
Well-
a weak antioxidant effect, which has nothing to do with it.
It's possible.
It's. I'm sorry.
The polyphenol effect, the weak antioxidant effect, or potentially anti-inflammatory
I think
effect.
it must be an anti-inflammatory.
It does have a weak COX-2 effect. That's been
Yeah.
shown
Yeah.
in
also
multiple
maybe
studies.
Weekly uric syrup, too.
But,
Well, but
it-
wouldn't we expect to see a urate lowering effect in that context?
I just don't think the studies are large or long enough to
Okay.
really fully appreciate the relatively small effect that you might see.
and there really aren't good studies like Lisa's that are out there, to be honest. So, Ken, what struck you?
Yeah. Well, I presented some data on what's called the ANAGO study. This was an active comparator looking at anakinra versus triamcinolone. Many of us in the gout field and many rheumatologists in general have been using some anakinra in their patients who aren't good candidates for other acute therapies, such as nonsteroidals, colchicine, or even glucocorticoids. So the impetus is to really generate some high-quality data in a real study, a real well-designed clinical trial that speaks to the efficacy of anakinra. The study was designed as a superiority study and, in fact, was not shown to be superior for the primary endpoint of pain measured using a visual analog scale. But it looks the same. Anakinra looks the same as triamcinolone in reducing pain, and in terms of a number of important secondary endpoints, it actually looked a little bit better. So we're not totally sure why pain is the same but other things are better. Regrettably, from a regulatory standpoint, it appears unlikely that this drug is going to move forward to approval as an indication for gout. So our issue in the U.S. at least is that we're going to continue to be using it off-label when we feel we absolutely need it.
But I think it's, again, really great to have some RCT data on anakinra, and we've also seen very similar data from the Netherlands as well with their RCT that's just been published. So, my sense is that at least for patients who, have contraindications or haven't had a good response to the kind of standard therapies, at least we now have some clinical trial data around safety, around efficacy.
Yeah, the safety looked fine in this study, and it makes sense pathophysiologically, given that the inflammasome is so important in the acute pathogenesis of gout, and we want to inhibit IL-1 as a primary biologic mechanism.
Rob, what struck you at this meeting?
So, the immunogenicity studies with pegloticase have been interesting in general, and it's kind of illuminated some, at least what, to my surprise, a little bit initially. I didn't think methotrexate, for example, would actually look like it had the response that it has with these patients and decreasing the potential risk for antibody development with pegloticase, as well as infusion reactions subsequently, or loss of efficacy in general.
Yeah, so this is a follow-up study to what was done sort of open label out in the community last year, and this is how many patients were in the study here?
How many patients have enrolled?
I think there are about 10 reported.
Yeah, there was a small report.
Yeah.
There's some really well-designed RCTs that are
coming, right?
underway.
Yeah.
One looking at methotrexate, one
Yeah.
looking at azathioprine. We finished a study looking at mycophenolate that hasn't reported out yet. So I think we're just not clear what's going to be the right strategy. It may be that all these things work. The other population that's going to be studied are transplant patients who are already on these drugs, and anecdotally we sense that they may be less likely to have immunogenicity as well. But this immunogenicity issue with pegloticase is really the treatment limiting problem with being able to continue it for more than a few doses, particularly in our younger patients where they're more likely to have a problem and a bump in serum urate that requires you to stop the therapy. You can't go further, and you don't want to have bad infusion reactions, which is what we worry about when the serum urate bumps.
So, Robin, your patients who you use pegloticase in, will you use a background drug like azathioprine, mycophenolate, or methotrexate?
I do, and I have. Yeah. So I've used azathioprine and I've used methotrexate.
Interesting.
So and I also have patients who are transplant patients who are on mycophenolate.
Works out well.
And works out well.
What about quality of care? What are each of you doing to address the issue of quality of care in gout?
Well, I think there's been some really interesting data at this meeting about some strategies for that. I mean, it's still really difficult, I have to say. One of the really interesting posters yesterday was a study looking at serum urate reference ranges. And within laboratories, huge differences in reference ranges. So, even if we're trying to treat to target, these, patients with hyperuricemia are not being flagged with gout and hyperuricemia, that we need to increase the urate levels. But I think at this meeting and over the last year or so, we've seen some really exciting strategies, new systems approaches, as well as nurse-led care, pharmacist-led care. So I think that we really need to look at how our healthcare system works, what the barriers are for patients, and try and address that. And I think we're really starting to see that.
Yeah, I think that's spot on. It's the old adage with trying to improve quality and change behavior, one size fits none. And unfortunately, our health systems are all so varied. But I agree with you that system approaches using nurses, pharmacists, other non-physician health professionals to help in this problem is really a promising approach. We actually have a study that we're just starting where we're going to be working from the ED and identifying people with gout in the emergency department, where we know a lot of people don't get the necessary follow-up, they don't get on urate lowering therapy, and trying to do a direct-to-patient approach to improve quality in that way. We'll see if that works.
The other thing that I think has been really interesting at this meeting is several abstracts which have shown that when patients get admitted to hospital, their allopurinol is stopped or reduced. And so again, we need to be looking at what's going on in hospitals, because that's a really lost opportunity. And in fact, it's even worse when you get admitted to hospital. So it's a real problem for hospitalists as well as primary care.
Well, it speaks to the battle with education and erasing the current dogma around gout and what gout is and how gout works, actually, even to the primary care physicians, the hospitalists, and really the bulk of gout patients sit in these offices with these physicians and providers, and it's always a battle to try to educate and get the word out and disseminate the word and how to appropriately treat and properly treat gout. And I think that goes along with everything else you've said as far as trying to change, our processes, the system itself, and that's just it's an uphill battle, but we're ready for it, right?
So what is this goutspecialist.org?
So this is goutspecialist.org is a network of gout specialists. You can sign up for, and as long as you adhere to the ACR guidelines as far as how to treat gout, you can sign up and be a gout specialist, and gout patients can actually find your name and your office location anywhere in the country, and it's only U.S. based right now, anywhere in the country to seek their gout treatment. And it's basically, and you can find that through gouteducation.org, and which has both physician or provider references and sources, as well as patient sources. And they get up in a range of 22,000 hits from predominantly patients on a regular basis, and it's just I think it's a good source for patients, and patients seem to love it. Of course, lots of gout cartoons, which my patients like, and I like as well. So it's a good opportunity for both patients and providers to get additional resources, as well as have their name out there as a gout specialist.
All right, we're on the elevator ride up with the viewer. We got 8 seconds each. What's the one thing you want to tell them about gout from this meeting?
Oh, I saw this amazing new therapeutic agent, which looks fantastic. So this is an enteric uricase, which is stable in the small intestine and looks like it's going to act on intestinal transport and has a urate lowering effect with an enteric agent that is not absorbed systemically. I think this is just new mechanism of action, really exciting. It's definitely the most exciting thing I've seen in gout at this meeting.
Cool.
So I know this is a gout session, but the thing we haven't talked about is asymptomatic hyperuricemia and the effects of hyperuricemia on other systems in the body. And there's been a lot of interest in cardiovascular disease and hypertension. At this meeting, my colleague Angelo Gaffo presented the SURFER study, which showed that allopurinol in a crossover design may actually have effects on vascular endothelium, although curiously that didn't translate into direct effects on blood pressure. So more to learn about that.
Yeah, gout is associated with multiple comorbidities and other disease states, as well as it's a very disabling condition for a lot of patients, and it's most importantly it's curable. And I think we need to get that word out that we can actually fix gout.
I just left Jazz Singh's poster about opioid use and trends in the United States, and it's actually gout's low on there, and it's not much of a problem, not compared to RA, OA, low back pain, other things. So thankfully, gout is not getting wrapped up in the opioid epidemic. I want to thank each of you for being a part of the panel. Thanks.
Thank you, Jack.
Thanks.
Thank you.